A very good evening. It is an immense pleasure to welcome you all to the classroom series of Neurocritical Care Society of India. Today we have with us two really eminent intensivists and neuroanesthetists in the field. Dr. Geetha, Madam is the head of the Department of Neuroanesthesia at MS Ramiah Hospital. Welcome, ma'am. It's a pleasure to have you as our moderator today. And I would like to introduce our speaker for today, Dr. Sapthami. She's done her critical care, she's done her EDIC, she's a consultant intensivist at Sparsh Hospital. So over to you, Dr. Sapthami. Today we'll be
Thank you,
discussing
Dr. Martin. Good evening, everyone. Good evening, everyone. Myself, Dr. Sapthami. Today I'll be talking about ventilator-associated pneumonia in neurocritical care. So let's start with a clinical vignette. So we have a 66-year-old man. He's got no medical history. He was admitted after a fall while working at his farm. On physical examination, he had aphasia and right upper and lower extremity weakness. CT had revealed a large left intercerebral hemorrhage. He was intubated on day 1 of hospitalization because of decreased level of consciousness. By day 7, he developed a temperature of 102, heart rate of 99, a BP of 140 by 50 with a respiratory rate of 16. So basically, he was tachypneic and febrile, and his FiO2 requirement increased from 40 to 60%. There was also a moderate amount of thick tan-colored tracheal secretions from the endotracheal tube, and on physical examination, there were decreased breath sounds on at the left lung base. There were no signs of exit site erythema or drainage at the CVC, right radial artery cath insertion sites, and no history of diarrhea. Basically, we're ruling out other signs of infection, and a urinary catheter was in place. Investigations, the peripheral blood leukocyte count was 17,600, and chest image revealed a new left lower lung field opacity. So I think you all would have guessed the diagnosis by now. This is a hospital-acquired infection. By day 7, patients start getting febrile. Probably has had a pneumonia, nosocomial pneumonia. So under broad headings, pneumonia is basically 3 types: community acquired, hospital acquired, and you have a ventilator acquired. Community is where the patient gets the pneumonia in the community. Hospital acquired is where he develops the pneumonia after 48 hours of hospital admission, and it did not appear to be incubating at the time of admission. That's important, and it does not require mechanical ventilation at the time of diagnosis. Whereas VAP is a subtype of hospital-acquired pneumonia, it occurs more than 48 to 72 hours after endotracheal intubation in the broad sense. So coming to the incidence and effect. So surveillance always underestimates a true VAP incidence. So this is very common because most of the VAP is a quality indicator in most of the ICUs. So VAP, most of the ICU people feel that, by overestimating or by showing the actual VAP incidence, it reflects bad in the ICU. So they underestimate the true VAP incidence. And also in the West, there is a problem that insurance can get rejected sometimes because if VAP is the diagnosis. So there are many reasons why the actual true incidence of VAP is always underestimated. But it constitutes nearly 22% of all the hospital-acquired infections, and 10% of patients who required mechanical ventilation were diagnosed eventually with VAP. 38% of patients who were ventilated for more than 48 hours developed VAP. So the incidence per se is 40 VAP per 1,000 mechanical ventilation days. That is the VAP rate. And the all-cause mortality associated with VAP is around 20 to 50% across various studies. Coming to the duration of mechanical ventilation is prolonged by 7.6 to 11.5 days, and the hospitalization duration is also increased by 11.5 to 13 days. And also the healthcare costs increase around 2.5 times after development of VAP. And among the organisms, 3 main organisms: Acinetobacter, Klebsiella, and Pseudomonas. A few studies, Klebsiella is more common, and few studies, Acinetobacter. So on an average, Acinetobacter was the most common, followed by Klebsiella and Pseudomonas. VAP is, as I said, it's a quality indicator in the ICUs. So we have to know the true VAP surveillance, there are 2 important definitions that we have to remember: the VAP rate and the device utilization rate. So VAP rate is defined as the rate per 1,000 ventilator days. It is calculated by the number of VAP divided by the number of ventilator days into 1,000. Okay, that is the ventilator days. And you have something called device utilization ratio. That is the ventilator utilization ratio. It is calculated by dividing the number of ventilator days by the number of the patient days. Okay, and this is performed separately by different types types of ICUs as per their patient intake. So many things vary, but usually on an average, VAP rate is the most commonly used for the VAP surveillance in the ICU. Now, coming to VAP in neuro ICU in particular, there are many studies, okay, and there were two or three huge meta-analysis which I could dig up. So one is the ENIO study. So there, the incidence in acute brain injury patients is around 31%, and the VAP rate in neuro ICU is 7 to 18 per thousand ventilator days. And the risk factors for VAP in neuro ICU mainly were impaired consciousness. So most patients will have low GCS. They might have swallowing dysfunction, old age, and also the sedation which we use in the neuro ICU. Okay, so this was a study I was talking about. The ENIO is basically, the study was for knowing the extubation strategies in the neurointensive care patients. So as a subgroup analysis, they studied upon the VAP incidence in the neurocritical care patients. So there they found that with available data on the VAP, all the patients who received mechanical ventilation for 48 hours with ICU length of stay more than 72 hours were included. So around 1,200 patients were included, and the VAP prevalence was around 39%. As I said, the risk factors were male patients who were smokers, who used intraparenchymal probe for ICU monitoring, EVD who had EVD in situ, or hypothermia was used in these patients. They had a more propensity for VAP. And the independent risk factors for VAP occurrence were male gender, use of this intraparenchymal probe, hypothermia, and also if there is occurrence of tracheobronchitis during the ICU stay. I'll be elaborating upon this tracheobronchitis in the future. So VAP was not an independent risk factor for ICU mortality. It was always an attributable mortality, okay, but it was independently associated with long ICU stay. One more study, this was also a meta-analysis, okay, in traumatic brain injury they did. It was there also, they found the VAP incidence was around 36%. So most of the studies, 30 to 40% is the VAP incidence in neuro ICU. Again, risk factors here were smoking, tracheostomy, blood transfusion on admission. So already they would have diseased lung with trally, then barbiturate infusion if used for sedation, then high injury severity score and high head abbreviated injury scale was related to occurrence of VAP. And VAP increased the mechanical ventilation time, ICU length of stay, and hospital stay. However, VAP was not associated directly with an increased risk of mortality. You have to remember that VAP is always an attributable risk for mortality, not a direct risk for mortality, because of associated confounders. So, in general, if you talk about the risk factors for VAP, we can study it under three headings. One is the host related. That is, patients can have already underlying medical conditions. They can be in a medical ICU. They can come with, CKD, uncontrolled diabetes, heart conditions, immunosuppressed patients, then COPD patients already having a diseased lung, patients with malnutrition with a very low albumin of less than 2.2, patients with ARDS, then patients' body position, patients, head low for a long time, or supine patients, level of consciousness, low GCS, then the number of intubations, the increased number of intubations, like reintubations, the more risk of VAP. Okay, and certain medications, prolonged neuromuscular blockers, steroids, and also sedations, which we use for these patients because of the low sensorium, and also PPIs, the proton pump inhibitors and H2 blockers. They also have an important role to play in VAP because they decrease the gastric pH. Then coming to again device-related, soil endotracheal tubes, ventilatory circuit, especially ventilatory circuit, repeated the changing of ventilatory circuits will result in increased incidence of VAP. That is why ventilatory circuits have to be changed only if they're visibly soiled. Then orogastric or nasogastric tubes. Then personal related. So most important is the hand washing technique. So improper hand washing technique, not following the 5 moments of hand hygiene. Then also the nurse ratio to the ventilator patient, failure to chain the gloves between the contact with the patients. Then also not isolating patients, high risk for MDR, MRSA patients, and not following adequate barrier precautions. They're all risk for VAP. So coming to the risk factors for multi-drug resistant VAP. So we have to remember this very important slide. So when do you think of multi-drug resistant from the patient empirically? So if the patient has a history of IV antibiotic use in the previous 90 days or 3 months, septic shock at the time of VAP. Okay, if patient has ARDS preceding the development of VAP, more than 5 days of hospitalization prior to the VAP. Okay, in your institute or previously also if he was hospitalized elsewhere, and a patient requiring RRT, okay, prior to the development of VAP. So these are indicators for MDR resistance. Coming to the pathogenesis of HAP and VAP. So as I said, as I already discussed all the risk factors, okay, the medications, then the invasive devices, like endotracheal tube, NG tube, and biofilm. Okay, this term is very important. So biofilm, basically, it is a bacterial aggregate along with polysaccharide. It forms a matrix and it lines the inside and the outside of the various devices, the endotracheal tube, and this can transmigrate into the lung, the biofilms. Then prior antibiotics, if the patient has been exposed to, and again host factors, immunosuppressed patients. This along with what I said, inadequate infection control practices, environmental factors. So all of this will result in, as soon as a patient is intubated, within 48 hours, there is 75% of the patients, there is transmigration of the aerodigestive tract organisms into the lung. Okay, so in all these factors will contribute to that. As a result, there is aspiration and patient will develop HAP and VAP. Along with this, the other associated factors is the patient's host defense mechanisms, like the mucociliary clearance will be reduced and the patient will be, immunocompromised, or there will also be transmigration from the gut or transthoracic inoculation or a primary bacteremia from elsewhere. All of this as a whole can contribute to the HAP or the VAP. So as you said, this picture, you can see the biofilm. So the common source will be the aspiration, the intubation procedure, the biofilm formation, and the secretions from elsewhere and the contaminated respiratory equipment. So once they form a biofilm, they can slowly, along with the aerodigested organism, the colonizers, it can transmigrate into the lung. And that's how we have the VAP. So coming to the causative organisms, so broadly, VAP is divided into early onset and late onset. So this it is not a very black and white division. There are gray areas in between. But just to have a fair idea, you have an early onset VAP that is less than 4 days of intubation, and late onset is more than 4 days. So early onset VAP, the organisms you see are very common and they're same organisms that are seen in a patient with a community acquired pneumonia, like Streptococcus pneumoniae, H. influenzae, MSSA, that is methicillin sensitive Staph aureus, or antibiotic sensitive GNB, E. coli, Klebsiella, sometimes even Enterobacter proteus. But in late onset, you can have the early onset organisms. Along with that, there are very high risk for MDR pathogens like Pseudomonas, Klebsiella, there is ESBL, sometimes even KPCs, NMDs, the newer ones, Acinetto, and also the MRSA. So these are the late onset organisms. So coming to the newer definitions of VAP. So VAP per se, the idea remains the same, that patient more than 48 hours, if he has an invasive ventilation, he develops VAP. But there are newer definitions which have been come up because of by CDC from 2013. This has been recently updated in 2023. So these are mainly surveillance definitions, and VAE is a ventilator associated event. From here, the point of VAE, you have further definitions like VAC, ventilator associated condition. So here it is a newer respiratory deterioration is seen in a patient who was stable for 2 calendar days, okay, who was requiring minimum PEEP and minimum FiO2. Suddenly, if there is a daily increase in the PEEP by more than 3 or increase in the FiO2 by more than 0.2 for more than equal to 2 calendar days, more than 48 hours, then that is called a ventilator associated condition. Next, what is IVAC? IVAC is infection-related ventilator associated complication. So VAC along with signs of clinical infection. So already I told you what is VAC. So VAC is increasing PEEP and FiO2. Along with this, if patient has a hypo or hyperthermia, okay, counts less than 4,000 or more than 12,000, or one or new antibiotics continued for more than 4 days, then it is IVAC. There is signs of infection start coming up. Then there is a possible VAP and a probable VAP. So the possible VAP, so here you have the IVAC along with the qualitative evidence of pulmonary infection. Okay, so that is within 2 calendar days. Of course, IVAC and VAC will be there. Along with that, patient should have a gram stain of endotracheal aspirate. That is, he should have more than 25 neutrophils. This is more of qualitative, not quantitative. Okay, and less than 10 epithelial cells per low power field. Why less than 10 epithelial cells? That will rule out any contamination, and more than 25 neutrophils indicates infection. He can have this, or he can have a positive culture. Then coming to the actual VAP is wherein he has VAC, IVAC, along with a positive culture. Positive culture is when it is more of quantitative, more than 10 to the power of 5 in the endotracheal aspirate, a positive ball, or a positive or a protected specimen brush of 10 to the power of 3 colony forming units. Or if he has a positive pleural fluid culture, a positive lung histopathology for the organism, or any atypical organism like Legionella or any of the viruses also, then that is a VAP. That is a possible VAP wherein he has the definitive organism. Now coming to the clinical definition. So previously the clinical definition was more broad, more simple. It just said patient should have an infiltrate in the x-ray, he should be febrile, count should be high, and should have purulent sputum. But this was not entirely capturing, it was overestimating the incidence of VAP. Why? Because infiltrates can be seen in so many conditions. Like in the ICU you can have infiltrates in x-ray because of fluid overload, ARDS, atelectasis, embolism, pulmonary embolism, contusions, effusion. So only the x-ray was only a very low predictive accuracy was there. Then coming to fever and leukocytosis, again there are many causes for this. There can be infectious and non-infectious causes for fever and leukocytosis. And coming to purulency of the sputum, this can also be seen sometimes in tracheobronchitis, reactive airways. So nothing is very specific for VAP. So because of this, only eventually of the diagnosed patients, only 50% would end up having VAP, and of course that would lead to overuse of antibiotics. So the newer definition was included by the CDC. It does not include, if you see, the radiological infiltrates. That is not a prerequisite for the diagnosis of VAP because of the high, low sensitivity of that. So that was removed. And also the newer definition aimed to reduce the subjectivity that was associated with the X-ray and the secretion. So especially X-ray infiltrates, there could be because of many reasons. Again, the purulency of the sputum, one might feel it highly purulent, one might feel that it was less purulent. So because of the subjectivity associated, these two were eliminated in the newer definition. So majority of the ventilator associated event they are caused by 4 conditions in the ICU. Most commonly it is pneumonia. Okay, as I said, a ventilator associated event is not entirely pneumonia. It can be other conditions also. Most commonly pneumonia 25 to 40%, fluid overload in 20 to 40%, atelectasis in 10 to 15%, and ARDS in 10 to 20%. So the positive predictive value of ventilator associated event as a screening tool for VAP is again low, and also the sensitivity is also low. Then one more entity is ventilator-associated tracheobronchitis. Okay, so here it is an infection of the lower tracheobronchial tree, but there is no involvement of the lung parenchyma. Only the tracheobronchial tree is involved. Again, it occurs 48 hours after mechanical ventilation. So it is infection is restricted to the bronchial lining and the alveoli are spared. It is thought of as a precursor to VAP or as a continuum between the colonization and the ultimate VAP. And progression to VAP is seen only in 10% patients. Not all VAP will eventually land up in VAP. Only 10% will lead to VAP. Hence, not all VAP will require antibiotic treatment. So we have to weigh the risk versus benefit. So if you look at this pathogenesis, as already discussed, the various bacterial pathogen and the lung defense mechanisms and other external factors, they will lead to tracheobronchial colonization. Following that, initially there will be a ventilator-associated tracheobronchitis. That is, the alveoli will be spared. Only in 10%, they will eventually land up in VAP. So if you see the differentiating feature between VAT and VAP, there is high temperature and purulency of sputum in both. But if you see, hypoxia is seen only in VAP. Hypoxia is not seen in VAT. So VAT patients will not have increasing FiO2 requirement or increasing PEEP requirement. Then there is no new infiltrate on the X-ray in VAT, but in VAT, there is a new and persistent infiltrate. Also, the cultures obviously will be negative in VAT and these will be positive in VAP. So hypoxia and lung infiltrates are the main differentiating feature. So coming to the National Healthcare Safety Network guidelines, these were the CDC guidelines. They updated in 2023. And then you have the IDSA guidelines, the Infectious Disease Society of America. These are the 2 American guidelines that form the skeletal for the VAP guidelines, which we also follow. But there are other guidelines also, the European guidelines, the ESICM guidelines, the ERS guidelines. So the gist of all the guidelines are same, but on certain conditions, they both of them differ. Like in American guidelines and European guidelines, one proposes for bronchoscopy and invasive sampling to for diagnosis, one does not propose for invasive sampling. And this ambiguity is there. That the result is, as a result, we should realize that there is no particular gold standard for diagnosis of VAP. Okay, so VAP, there is no 100% way to say that the patient has VAP. The only 100% way to say is by autopsy, which cannot be done, obviously. So it should be more of a clinical, along with this investigations, which will help hand in hand. And that is how we should come to the diagnosis of VAP. So we should always revise our diagnosis every 24 to 48 hours, because the guidelines differ, and there is no 100% accuracy in which we can tell the patient has VAP. So what are the problems with diagnosis and treatment? So one is the undertreatment. Okay, so you'll be waiting to the patient septic shock to escalate antibiotics or to put on higher end antibiotics. So sometimes you'll end up undertreating the patient. One more problem is sometimes you will overtreat the patient initially by starting on high-end antibiotics initially itself. That will result in antibiotic misuse, or for all purpose, there might not be even VAP initially. So eventually, later we might come to know, and that will result in antibiotic misuse. Under investigation, sometimes you will assume diagnosis even without further investigation. So initially, if the counts are high, patient is having fever, some purulent secretions, you might underestimate, investigate, and think that patient already has VAP, and you start him on higher antibiotics, or over investigating. Any infiltrate on X-ray, you end up getting a CT scan done or a bronchoscopy done for the patient, so that will lead to over investigation. So these are all the problems with diagnosis and treatment of VAP. So this is a diagnostic and therapeutic pathway that we can follow. Again, there is no gold standard, but this gives a rough picture as to how to go about the therapeutic diagnostic pathway for VAP. So one is a possible VAP. So three things if a patient comes and you're suspecting VAP. So first, look for signs of inflammation. So any counts are high, okay, fever, hypothermia, the patient is in shock. Then any evidence of pneumonia, purulent secretions, high FiO2 requirement, PEEP requirement. Then any X-ray infiltrates. If a CT is already done, then you'll have a CT report. So after all this, if you think the patient actually has VAP, then you go ahead and do further investigations. You send for cultures, nasal, PCR for MRSA. If he's coming from outside hospital, you send for blood cultures. Procalcitonin only if the patient is immunocompromised, or sometimes as a baseline you can send, but that should not be the criteria to initiate antibiotic. And you can repeat the imaging in 1 to 2 days. Then you always have to review the data in 24 to 72 hours. So once you think it's VAP and you start antibiotics, the job is not done there. You always have to review the data every 1 to 2 days. So is there a data that strongly argues against VAP you have to look for? So if the procal is very low, okay, and sputum is not showing any signs of inflammation, the culture is not growing any bacteria, and X-ray is showing resolution of the infiltrate, probably because it was an atelectasis to begin with and you thought it's a VAP and you treated the patient. So if these things are arguing against VAP or for a VAP, you have to see. So if these are ruled out and you still feel it is VAP, then you will confirm it only by microbiology. So narrow the antibiotics based on sputum culture. For sputum culture to come, it will require again 24 to 48 hours for the final report to come. So for that, after you get it, you have to narrow down or step down the antibiotics. Then even if the VAP diagnosis is not considered, as I said, every 1 to 2 days, you have to revisit your diagnosis and think of other causes like, atelectasis, pulmonary embolism, aspiration pneumonia, okay, ARDS, etc. So this is that's, as I already spoke, the evidence of inflammation. You can see the counts, leukocytosis. Again, the sensitivity is around 60 to 50%. Fever, again, the sensitivity is around 60 to 50% for VAP. You'll be looking for other predictors of inflammation like hypothermia, septic shock. Again, for pulmonary dysfunction, secretions, the sensitivity is around 70%. Then you will see for decline in oxygenation, any respiratory dysfunction features. X-ray we spoke about in detail. Lung ultrasound is one more useful modality. It is available, I think, in most of the ICUs now. Of course, it is less useful for VAP because in ICU most of them will be in supine position. They'll have some amount of atelectasis, dependent consolidation, but still it can have a negative predictive value, and sometimes you can distinguish pleural effusion from consolidation at the lung basis. So there the utility is there. Then the CT scan, if nothing works out and you're still not sure of your diagnosis, then CT will be the 100% way sensitive way to tell whether there's a pneumonia or not. But of course, that comes with the challenge of transporting a hypoxic patient to the CT console. So yeah, the radiographic evidence. Then other diagnostic techniques will be the blood cultures. So even though it is pneumonia, you always have to work up. You have to do a pan culture. You have to work up for blood cultures, two sets of peripheral blood culture, aerobic, anaerobic. At the central line, send one more concomitant blood culture from the central line. Tracheal aspirate for gram stain culture. PCR studies for probable viruses. Virus infections as a VAP is very rare, but it is possible in a hospital setting. Nasal PCR for MRSA. Then procal level baseline and radiological data. Also, if the patient is, immunocompromised, if he's on long-term steroids, neutropenic, of course, not in neuro patients, but solid organ transplant patients, you have to consider, even invasive aspergillosis a possible diagnosis, and you have to think of CT, serum galactomannan, and beta-D-glucan levels. So bronchoscopy is the cornerstone of the diagnosis, of VAP, the probable VAP. So again, you have the invasive, non-invasive techniques. In that, you have the BAL and the protective specimen brush. In the non-invasive, you have the endotracheal aspirate, the mini BAL technique, which we follow. So these are the threshold values for cultured specimens. So as you can see, for lung tissue to be positive, the value should be, this is the quantitative, it should be more than 10 to the power of 4 colony forming units. Okay. And for BAL, it should be more than 10 to the power of 4. Even for PSB specimens, it is more than 10 to the power of 4. For non-BAL, it is around 10 to the power of 4. And for ET, it is the highest. Endotracheal aspirate is 10 to the power of 5. So you can just remember that for endotracheal aspirate, the colony count should be high, more than 10 to the power of 5. And for others, it is around 10 to the power of 4. So come to tracheal aspirate, how will you differentiate whether it is a commensal or not? So if there is evidence of squamous epithelial cells in the sample, if you get the initial the quantitative sample saying squamous epithelial cells more than 10 per low power field, that indicates it's a contaminated sample with mouth secretions. And if there is macrophages, it indicates the sample is from the lower respiratory tract. If the neutrophil count is more than 25, then it indicates infection. Okay, so the qualitative, the sensitivity is around more than 90 and specificity is less than 40. And for quantitative, it is around 76% sensitivity and specificity 75. Okay, so quantitative always increases the specificity of diagnosis, as I previously said. Coming to BAL, it is performed by wedging the bronchoscope in the distal airway, and you perform a lavage with isotonic saline. So ideally, you have to perform 6 lavages with 20 ml isotonic saline each time, and the minimum lavage volume that's recommended is 120 to 140 ml. So when intracellular organisms are present in over 3% of the cells in the lavage fluid, the likelihood of pneumonia is over 90%. Coming to the mini BAL technique, it is similar to BAL, but a sheath catheter is actually advanced through the endotracheal tube blindly till it wedges in the distal airway, and later you introduce an inner cannula for the BAL. So here at the tip, you'll have an adsorbable polyethylene plug. Okay, that will prevent the contamination while the catheter is advanced. And then you have the protected specimen brush. So even with BAL, there's always a risk of contamination, because as it goes, there's contamination through the tracheal tubes, upper respiratory tract. To prevent that, you have the protected specimen brush. So here it is advanced from the inner cannula to collect samples from the distal airway. So this is the performance characteristics of the various techniques. So ET aspirate, protect specimen brushes, and BAL. So you can see the prostate predictive value is higher for ET aspirate, provided it's more than 10 to the power of 5. So the IDSA guidelines, the American guidelines, they suggest non-invasive sampling with semi-quantitative cultures to diagnose VAP than the invasive ones, that is bronchoscopy methods with quantitative cultures, and non-invasive sampling with quantitative. So recommended is non-invasive, that is ET aspirations can be done with semi-quantitative cultures to diagnose VAP, because you can't wait to start antibiotics till you do invasive techniques. So that is the whole idea of asking for non-invasive sampling. Then the various clinical criteria for diagnosis of VAP, of course, most of them are not validated anymore, and we don't follow them anymore. So previously we had the Johansson criteria, where presence of a new or a progressive radiograph infiltrate along with fever, high counts, purulent secretion. That was the criteria. Then you have the CPI score. I think you all are very familiar with this clinical pulmonary infection score. It was a 5-point score. A total score of more than 6 will suggest VAP. That is temperature of the patient, blood leukocytes, oxygenation, the PF ratios, the pulmonary radiography infiltrates, and tracheal secretions. Again, the IDSC guidelines don't recommend VAP for diagnosis or treatment based on the CPI score. always it has to be combined with the clinical criteria. Then you have the CDC criteria, which are not followed much. Again, this is based on radiological science, microbiology criteria, then other clinical science, and the signs of any hypoxia, tachypnea, and purulency of secretions. So to summarize the diagnosis, it mainly, if you're suspecting VAP, you will have to obtain a lower respiratory tract sample for culture and microscopy along with another pan cultures. Okay, so unless there's a low suspicion for pneumonia or already there's a negative microscopy of the LRTI sample, lower respiratory tract sample, just begin an empirical antibiotic therapy. Okay, then you have to revisit and check the culture, assess the clinical response again, look for signs like, if the patient is continuing to have temperature, counts are high, chest X-ray oxygenation, the color of the secretions, if he's hemodynamically stable. Then if there is a clinical improvement and cultures are negative, you can think about stopping antibiotics. If cultures are positive, then you will have to de-escalate antibiotic or probably narrow down your antibiotic as per the sensitivity. If there's no clinical improvement and the cultures are negative, look for other sources of infection. And if the cultures are positive, then probably we'll have to hike up antibiotics and look for other sources of infection, or other, you'll have to revisit your diagnosis. So coming to the use of bronchoscopy in particular, so there were a few trials, one by the Canadian Critical Care Trials Group. So also IDOC also does not recommend routine diagnostic bronchoscopy for all patients of suspected VAP. It can lead probably to delay in initiation of antibiotic therapy only in certain conditions, like if you're suspecting, especially immunocompromised like pneumocystic pneumonia or invasive aspergillosis, then only bronchoscopy is indicated, because again requires expertise, time, personal, not much added benefit, and it can add to the cost also. Also, bronchoscopy is superior to minibal, of course, because you have visualization of the mucosa as you go through, especially for tracheal aspergillosis. You can see blackish discoloration of the mucosa. You can target involved areas of the lung. Therapeutic approach also is possible simultaneously. And if at all a bronchoscopy is performed, the differential cell count should be obtained. So if it's less than 50% of the cells are neutrophils, then it probably excludes the pneumonia. Coming to biomarkers in VAP. So one, procalcitonin. As already said, you should never use serum procalcitonin to initiate antibiotics. It's mainly used to de-escalate. Other biomarkers like STREM, okay, and CRP and the CPI score, they also should not be used to initiate treatment. They can be used, but also along with clinical criteria. They should not be used alone as they're not much of use if used alone. Then coming to the comparison of early onset and late onset VAP. So our antibiotic therapy, as soon as we receive a patient, so based on that, should we decide the antibiotics for the patient is also important. So there are few studies. I have just 2-3 studies I've put. So 1 or 2 large clinical studies which you have seen, where they compared the bacterial etiology of early onset and late onset ventilator associated pneumonia for antibiotic decision. So there was no significant difference in the prevalence of the MDI pathogens between the two groups. Okay, and empiric therapy for early onset VAP should also include agents likely to be effective for potential MDR, especially for those who are high risk for MDR. And of course, you require further studies for this. One more is the impact of the onset time on the isolated pathogens and outcomes in VAP. So in this study also, the occurrence of potential multi-drug resistant pathogen and the mortality risk was similar, regardless of the VAP timing, whether it was early or late. And mortality risk also was similar between the two groups. And the bacterial isolates that were isolated from the VAP cases did not follow, early versus late pattern. And hence these terms, are not much used nowadays, early VAP or late VAP. Our antibiotics should be such that they have to cover most of the organisms. So there have to be broad spectrum antibiotics. So how do you start treatment for a patient of VAP? So you come to a diagnosis of VAP. So our empirical therapy should be based on the local antibiogram of that ICU. Okay, so as per your susceptibility, antibiograms and the susceptibility, we have to start. But as a, in general, always you have to start with a broad spectrum antibiotic. So beta lactams will be the backbone. So usually ceftriaxone should be enough for most of the patients, provided they are not at risk for MDR. If they are risk for pseudomonas or they have risk for MDR, if they have septic shock, some structural lung diseases like COPDs, ILDs, okay, cystic fibrosis, okay, he's already received antibiotics for last 7 days, he's hospitalized in the last 3 months for more than 1 day, immunocompromised, okay, nursing home resident, in and out of hospital for dialysis, wound dressings. Such patients, you have to hike up the antibiotics. Probably start off with a cefepime or a piptaz. If he has a history of penicillin allergies, then maybe you can consider carbapenems. Otherwise, carbapenem should not be your first choice. And don't use ceftazidime because the gram positive coverage is not that great. Okay, and atypical coverage should always be there. Okay, for such patients, any azithromycin 500 should be enough. Or if there is a contraindication to azithromycin, then doxycycline also should suffice. So, if do you cover all the patients for MRSA in your ICU if there is suspected VAP? No, only in selected cases. I'll be discussing that later. In those patients, if there's a high risk for MRSA, you'll be covering the for MRSA with linezolid or vancomycin. Linezolid will be the first choice. So when do you start MRSA? So indications for empirical MRSA will be a short score. So the score is not validated, but it will give you an approximate idea of the high risk patients. So if this age less, very young patient less than 30 or elderly patients, hospitalized patients for last 3 months, nursing home patients, IV antibiotics in last month, very sick patients in shock, then CVA, if they have a history of CVA, dementia, and females with uncontrolled diabetes, then if a score of 6 to 10, then you have to consider empirical MRSA in these patients. If they have a cavitated pneumonia in radiology, post-influenza pneumonia, IV drug abusers, if they have a skin pustules, suggestive of MRSA, and if they have a known prior colonization with MRSA, then all these things you can start off with a linezolid or vancomycin. So cover for MRSA, but you have to reevaluate it within 24 hours. So look for NAS MRSA. Okay, so any patient coming from outside hospital facility, you always take a nasal swab for MRSA. So if that is negative and procal is negative, then don't treat for MRSA. Otherwise, you continue MRSA and again revisit the patient. Like you go for positive MRSA PCRs and cultures. Okay, so you always have to revisit your diagnosis because MRSA, the treatment is for a long time, not like the regular VAP. So you'll have to be very clear before starting the MRSA treatment. So coming to IDSA guidelines, in patients with suspected VAP, they recommend including coverage for staph aureus. I already told you broad spectrum should be there, and coverage for MRSA should be only in those units if there is a risk factor for MRSA, or if your particular ICU unit, if there's more than 10 to 20% staph aureus isolates are methicillin resistant. Only in such units you have to cover empirically for MRSA. Okay, and 2 anti-pseudomal antibiotics from different classes for the empirical treatment of suspected VAP is done only if the patient is very sick. Okay, that is, he's got an antibiotic resistant risk factor, high risk for MDRs, more than 10% resistance to an agent in one of the monotherapies. Then only you go for dual therapy. Otherwise, routinely you don't have to go for dual therapy. Okay, and avoid aminoglycosides of other agents with adequate GNB cover available. So this is a chart which shows suggested empirical treatment for clinically suspected VAP. Okay, so as you can see for MRSA, glycopeptides, vancomycin or linezolid can be used. For beta lactams, for gram-negative antibiotics, anti-pseudomonals, usually piperacillin, tizobactam, cefepime, ceftazidime. Ceftazidime, of course, gram-positive coverage is low. Then carbapenems, only sometimes if you have carbapenem peptidase allergy, okay, you can go, or monobactams. Non-beta lactam based agents, sometimes if they have severe allergies for penicillin, you can consider fluoroquinolines, aminoglycosides, or polymyxins, but it's not a good idea to start off with these agents. So one word of caution about fluoroquinolones. So fluoroquinolones, they are not to be routinely used in all the patients. Or supposing patient has penicillin allergies, you can still, go for third and fourth generation cephalosporin than going for a fluoroquinolone because they are noted to cause, inducible resistance. Okay, and they breed, MDR resistant organisms. They are known to cause C. diff colitis. Okay, and they also can block the GABA receptors and they can stimulate the NMDA receptors. So they can cause delirium and seizures. And recently, FDA has released a boxed warning, regarding fluoroquinolones because they can cause a persistent, debilitating peripheral neuropathy. And of course, India, as we know, is very endemic for tuberculosis, so we have to use fluoroquinolones sparingly. So that should be the last choice. Coming to ventilator-associated tracheobronchitis. So we already spoke about this. So should these patients receive antibiotic therapy? So according to IDSA, in patients with ventilator-associated tracheobronchitis, we suggest not providing antibiotic therapy. But that is a very weak recommendation, low quality evidence, because 10% can eventually land up in VAP. So if a patient with VAP, presents with septic shock, is very sick clinically, then you can consider antibiotics. So case-wise, we have to weigh the risk and benefit and then decide. Coming to inhaled antibiotics. So for patients with VAP, because of a GNB that is susceptible to only aminoglycosides or polymyxins, we suggest both inhaled and systemic antibiotics rather than systemic antibiotics alone. So I'm not sure, routinely most of you use inhaled antibiotics in your ICU, but that should be a last resort. Very sick patients, non-resolving VAP, and if at all you decide to use your inhaled antibiotic, it should always be combined with a systemic antibiotic. Remember, you should never use inhaled antibiotics alone. It should always be with a systemic antibiotic. So theoretically, the pros and cons of nebulized and IV antibiotics. As we know, nebulized antibiotics, they achieve high pulmonary concentrations. The concentrations are well above the MICs, and they improve efficacy, especially for concentration-dependent antibiotics, especially amikacin. They work very well in inhaled antibiotics. Then they have a less systemic side effects. But IV antibiotics, we know they have high extrapulmonary concentrations are achieved, but they come with toxicities, and the delivery to the lung is very limited, and lung concentration might not exceed the MIC, and sometimes it can lead to treatment failure. This is more of theoretical. But coming, if you look at the RCTs and the meta-analysis, most of them nebulized antibiotics. You have in 2015 around 15 studies were included in this. So they said that nebulized antibiotics were associated with high rates of clinical cure in treatment of VAP, but the apparent benefit was, in the clinical cure rate, was not very apparent, was not very obvious. So further studies are required, they say. Similarly, regarding aerosolized colistin, okay, one more meta-analysis. So aerosolized colistin is associated with improved outcome in treatment of VAP, but the evidence of level of evidence was low. Then one more in tracheobronchitis. Okay, one more study. Here they saw in critically ill patients with ventilator-associated tracheobronchitis, aerosolized antibiotics will decrease VAP and other signs and symptoms of respiratory infection. They facilitate weaning and they reduce the resistance in use of systemic antibiotics. So from the studies, what we can find out is that there is some role in ventilator-associated tracheobronchitis because the lung parenchyma is not involved. So they will help some amount in aerosol in ventilator-associated tracheobronchitis. But if you're planning to use it in VAP, then you always have to use it as a dual therapy with inhaled along with systemic antibiotics. And one more thing, whenever you're using inhaled aerosolized antibiotics, you have to use the appropriate nebulizer. So the regular nebulizers which you use for bronchodilators, if you use that, you and the staff around you will end up inhaling the antibiotics. So ideally, you have to use the vibrating mesh nebulizers and the ultrasonic nebulizers which are available. Only they can, deliver the drug. I think less than 5 microns, they will be delivered to the lung alveoli. Otherwise, the routine nebulizers which you use for the inhaled antibiotics are not of much use. Of mention is as recent, I think 1 month back, this trial has come, the Amikin Hall trial. So this is in the New England Journal. So they saw the inhaled amikacin to prevent VAP. So in this study, they saw that patients on mechanical ventilators for at least 72 hours received inhaled amikacin at a dose of 20 mg per kg of ideal body weight once daily, or they received placebo, okay, for 3 days. They saw that 3-day course of inhaled amikacin will reduce the burden of VAP during the 20-day or 28-day follow-up. So this was a very promising trial, a recent positive study, because most of the previous studies are negative studies or nothing conclusive came out of it. So probably in the future studies in on amikacin will throw more light whether we can use amikacin or not. But concentration dependent diabetes have some role if used as aerosolized antibiotics compared to other antibiotics. And of course, the FDA approved inhaled antibiotics, if I'm not wrong, are only colistin and tobramycin. Okay, so of recently amikacin has been introduced. Coming to the duration of the therapy. So how long should you give the antibiotic therapy in VAP? So the IDSA and the ATS guidelines generally recommend a 7-day course of antibiotics. Of course, these are not tailor-made. It's not like 7 days you give and you stop. So you will have to look at the patient clinically, and other criteria also should be thought of. But there are potential indications of prolonged therapy. So certainly in some conditions, they definitely need for a long time, like empyema or a lung abscess or a necrotizing pneumonia, like an MRSA. Then bacteremia with certain gram-positive organisms, immunodeficient patients, and certain that is cystic fibrosis patients. And procalcitonin can be useful to shorten the duration of therapy. And if you find the procal falling below 20% of the initial value or less than 0.25, there it is safe to discontinue antibiotics. Of course, you also have to look at the clinical criteria. So there are few trials comparing 8 versus 15 days of antibiotic therapy, okay, for VAP. 2 3 trials, important trials, and most of the trials I saw that ICU patients who develop microbiologically proven VAP, there was no clinical advantage of prolonging the antimicrobial therapy to 15 days compared to 8 days. So more time you give, it's not like it will do wonders. So up to 8 days it is recommended. Again, you will have to see the patient clinically. Coming to antibiotic de-escalation. So for patients with HAP or VAP, the recommended is that, as per the IDSA, antibiotic therapy be de-escalated rather than fixed. And for de-escalation, we suggest using procalcitonin levels plus clinical criteria to guide the discontinuation of antibiotic therapy rather than clinical criteria alone. So if you see here, so procal is never used for initiation of antibiotic. But for de-escalation, even surviving sepsis guidelines and the VAP guidelines, they suggest for de-escalation. So antibiotic de-escalation, VAP can occur sometimes without an organism being cultured. So sometimes, even though cultures are negative, there can be a possibility of VAP. So what are those conditions? So if the antibiotics were given prior to the sputum culture, okay, then obviously you might not have any growth in the culture. Then early onset VAP leading to infection with atypical fastidious organisms, and if there is a concern for VAP is despite negative culture, there is nothing wrong in continuing the treatment. Okay. And if the cultures are negative, then always we have to de-escalate or narrow down the antibiotics. So what are the benefits of de-escalation? One is unaltered clinical outcome. Outcome will be the same compared to the maintenance of the initial therapy, improved antimicrobial resistant patterns, decreased antibiotic side effects, and overall the antimicrobial cost can also come down. So this is the projection for 2050. So as you can see, compared to all the serious diseases like even cancer, road traffic accidents, they have seen that the projection for 2050, the antimicrobial resistant deaths are around 10 million. So we have to be very sparingly of to use antibiotics, and we should always de-escalate at the earliest. So coming to the summary of the VAP treatment. So first, very simple, you have to initiate appropriate therapy based on the antimicrobial pattern, susceptibility, antibiograms, local antibiograms, then combination therapy if it is associated with septic shock or patient is very sick, risk for MDR organisms. De-escalate as soon as possible. Always use Procal with the clinical criteria, both together. Nebulized antibiotics in selected indications can be used. It should be used as a last resort. Never use it as a monotherapy. Always combine with a systemic therapy and use the appropriate nebulizer. And short course of antibiotics in most of the cases of 8 to 10 days should suffice. So treatment failure. So there are certain conditions that in spite of doing everything, there can be a treatment failure. So what do you have to, how do you troubleshoot there? There you have to look whether, you have targeted the wrong organism, like drug resistant organisms, probably any associated, any new viruses, then atypical fungi, mycobacterium, or if there was an inadequate antibiotic therapy itself to begin with, the wrong dose or the wrong organism or the wrong antibiotic. Then wrong diagnosis itself, like if it is a non-VAP condition, like, ARDS, pulmonary embolism, atelectasis, a hemorrhage or carcinoma, or any other underlying disease. Then complications, sometimes empyema, lung abscess, like a closed abscess, they might not respond to the antibiotic therapy, okay, because of poor penetration, or C. diff colitis, occult infections, drug fever. So we have to think of all these possible reasons for treatment failure. Coming to the mortality predictors in VAP, so usually the most commonly used is Apache 2, but some papers they have mentioned about the IBMP 10 score that has got a greater sensitivity, specificity, and area under curve to predict mortality compared to Apache 2. But of course, larger RCTs is needed. Just for you to know, the IBMP is a 10. IBMP 10 score includes 5 points like immunodeficiency, low BP, multilobar infiltrates, low platelets, and duration of hospitalization before onset of VAP. Okay, but it's not a validated score. Okay. So much for VAP. Now we'll have to think about prevention of VAP. This is the most important aspect of VAP. So in all our ICUs, we have to practice this. So prevention is better than cure. We have the VAP bundle, but of course, many changes have been brought about to the VAP bundle. The cornerstone of VAP prevention will be first the few important things, elements of preventive bundles that we have to follow on a day-to-day basis in the ICU. So first, prop up of all the patients, 30-degree prop up. Of course, neuro ICU will be following this, but this has to be followed stringently. Then sedation hold, daily sedation holidays, daily spontaneous breathing trials for all the patient, monitoring cuff pressure. Okay, it need not be a continuous monitoring, but monitoring on regular shift basis is very important. Subglottic suction and hand hygiene is the most important. Okay, following the five important moments of hand hygiene for 20 seconds. And of course, the nurse ratio has to be improved in most of the ICUs. Ideally, it has to be 1:1, sister for one ventilator patient. Most of the ICUs are difficult to achieve that, but we have to, if patient is MRSA or MDR, we have to quickly isolate and follow appropriate barrier precautions. So again, strategies to prevent the VAP. This has been there's a recent 22 update that has been given by the IDSA. So as per that, I'll just summarize. So certain essential practices with the quality of evidence. So avoid intubation wherever possible and prevent reintubation. So wherever possible, like COPD patients who are coming, try to give them a good trial of NIV, high flow wherever possible. Try to avoid intubation as much as possible. And whenever you are extubating these patients, see that they fulfill all the extubation criteria before extubation, because another reintubation, the risk of VAP will be much higher. Then it's got a high evidence. Then minimize sedation. So adequate, avoid benzodiazepines in favor of other agents. So newer agents, like dexmedetomidine have come. So avoid benzodiazepines. Use a protocol. So protocolized sedation, then protocolized weaning should be done. So implement a ventilator liberation protocol. So moderate evidence. Then elevate the head of the bed to 30 to 45 degree. Okay, actually it is a low quality evidence because there are not much RCTs that have proven, okay, the actual position of the patient. Then provide oral care with tooth brushing but without chlorhexidine. That is moderate evidence. Okay, then provide early parenteral versus enteral versus parenteral. So early enteral will prevent the transmigration of the gut bacteria. Okay, so early enteral whenever possible, and try to avoid TPN. Change the ventilator circuit only if visibly soiled or malfunction. So unnecessary ventilator circuits are not recommended, only if it is soiled. Then additional approaches: use selective oral or digestive decontamination in countries and ICU with low prevalence of antibiotic resistant organisms. So SDT, SOD has been advocated in the past in the West, but again, this comes with the risk of antibiotic resistance. So you can use it in prevalence with ICUs with low prevalence of antibiotic resistance. Then utilize endotracheal tubes with subglottic secretion drainage ports for patients expected to require more than 48 to 72 hours. So if they're requiring long mechanical ventilation, always use a subglottic suction. Consider early tracheostomy. There is moderate evidence, the Trackman trial, but again there's not much evidence for this. Okay, then consider post pyloric rather than gastric feeding for patients with gastric intolerance or high risk for aspiration. That is also moderate evidence. So generally not recommended are all these recommendations. Oral care with chlorhexidine, so the regular oral care in ICU with chlorhexidine, not much evidence for that. Probiotics, then ultra thin polyurethane endotracheal cuffs, tapered endotracheal tube cuffs, automated control of endotracheal tube cuff pressure. Frequent cuff pressure monitoring is not required. Silver coated endotracheal tubes and antimicrobial impregnated tubes are not required. Kinetic beds, prone positioning, no, not much evidence. Chlorhexidine bathing, whole body chlorhexidine bathing, no evidence. Stress ulcer prophylaxis, routine stress ulcer prophylaxis, we all know now. Now we know better that routine prophylaxis is not need for all our patients. Of course, traumatic injury patients, brain injury patients will have to give stress ulcer prophylaxis. Monitoring residual gastric volumes routinely is not recommended. And early TPN is not recommended. Definitely, there is no recommendation for closed endotracheal suctioning systems. Okay, subglottic suctioning should suffice. So body position, okay, this is a very important meta-analysis for preventing VAP. So in this study, this semi-recumbent and prone position they saw was a significantly low risk for VAP, okay, compared to supine. Okay, but the optimal position of mechanically ventilated patients, it is still, it is contentious. Okay, there is no high quality evidence among all the trials which says that any particular position of the patient they'll reduce VAP. But we follow the 30-degree elevation in all our ICUs. Effect of oral chlorhexidine. Okay, so oral effect on nosocomial pneumonia. So there were 22 RCTs which were included as a huge study. They saw that it reduced the incidence of pneumonia, nosocomial pneumonia, that is HAP and VAP, but there was no effect on the mortality. because this study was mainly in cardiac patients. Okay, so it is mainly in surgical on cardiac patients, and it reduced both gram negative, gram positive, and staph aureus. But it does not have effect. It did not affect mortality, and further RCTs are needed in non-surgical critically ill patients. Okay, and only in cardiac patient there was some benefit. Then in what concentration we have to use the chlorhexidine? So this was one more meta-analysis here. So here they saw that 18 RCTs were included, and this had this when used in 0.12%, concentration the chlorhexidine, that had a significant effect on the decreasing the VAP. So it should be, or if at all using chlorhexidine, it should be equal or greater than 0.12%. So the thing is, chlorhexidine is like a placebo. It should not cause much side effects, systemic effects. So though there is not very high quality evidence for chlorhexidine, in a concentration of 0.12%, you can use it in your ICUs. Okay. Then a few more studies are impact of oral care, okay, with or without toothbrushing on the prevention of VAP. One more is on mechanically ventilated patients where the toothbrushing had any decreasing the VAP. So there were some 6 trials here. One study it included. So they saw that use of chlorhexidine anti-sepsis seems to attenuate the effect of toothbrushing on VAP. So it did not impact the length. Okay, mortality. So mortality is a bigger term. Just a small thing like toothbrush or chlorhexidine, it cannot directly reflect upon the mortality, but it did not impact much on the ICU stay or hospital stay either. Then regarding toothbrushing, one more Gu et al. 4 studies were included. Again, toothbrushing did not significantly reduce the incidence of VAP and intensive care mortality. So toothbrushing as such, not much evidence. Then coming to oral povidone iodine preventive oral care. So again, there was no there was one important study where they saw around 180 brain injury patients. There are they received oropharyngeal care with povidone iodine and placebo. So they saw that VAP occurred in 24 patients with who used povidone iodine and 20 in placebo. So again, there was no significant difference between the two groups in terms of VAP. Okay, again, whole body chlorhexidine bathing. There was a reduction in hospital-acquired infection, but not VAP per se. Okay, so in conclusion, okay, in the background of the use of chlorhexidine, toothbrush significance is not known. So we don't know if there are not much trials on RCTs as well, small studies. So theoretically, toothbrush, it should remove plaques, it should remove the biofilm with added risk of tube displacement. So that occurs early morning. They'll give oral care sisters bedside, the high risk of accidental extubation, and that has a high risk of re-intubation. So toothbrush, not much recommendation. So current evidence is divided over same, but individual RCTs, they have shown good outcome with use of toothbrush. So you can use it maybe a frequency of 1 to twice a day. There are different commercially available toothbrush for ICU patients available now. For oral hygiene care, including chlorhexidine mouthwash or gel, they reduce the risk of developing VAP in critically ill patients from 25 to 19%. So considering, as I already told you, chlorhexidine is a very safe thing to use, so it can be recommended for all patients. Okay, but other antibiotic mixtures, that is not recommended, and povidone iodine is also not very helpful. Coming to selective oral decontamination. So we had this landmark paper wherein the decontamination of digestive tract and oropharynx in ICU patients were studied. So basically, selective digestive decontamination, what is it? It consists of 4 days of giving IV cefotaxime to the patient. Along with it, simultaneously, you will be using a topical application of 3 antibiotics, tobramycin, colistin, and amphotericin, and that you'll be using in the oropharynx and stomach. So the surveillance cultures of the endotracheal aspirates and oropharyngeal rectal swabs, they were obtained on admission and then twice weekly after. So the antibiotic resistance was also monitored, okay, on every third Tuesday of every month in the study. So SOD, that is selective oral decontamination, is similar to selective digestive decontamination. Only difference is in SOD you give the same paste, but you don't give IV cefotaxime. So they saw an absolute risk reduction in mortality, okay, at day 28 with SDD and SOD. But they saw that the cost per day went up, okay, without much evidence of emergence of antibiotic resistant pathogens, okay, and there was not increased rates of C. diff. This was done in the West, of course. So there are some limitations of this study. There was no restriction of use of other antibiotics for these patients. There was no blinding. It was poorly conducted randomization. There was no long-term follow-up of these patients, because they were exposed to all these antibiotics, and the definition of VAP was not clearly defined. Okay, this was before the CDC criteria came. So conclusion is that SDD with systemic antimicrobial therapy reduce the mortality, but long-term consequences of overuse of antibiotics that can be grave. We don't know. Long-term follow-up is not done. It will add definitely to the cost of therapy. You're using colistin, you're using amphotericin, they're all costly antibiotics, and how much benefit it is providing, we don't know. So definitely, it is not recommended in countries where there is high risk of antimicrobial resistance. Coming to subglottic suction, subglottic secretion suction for preventing VAP. Okay, I think most of the ICUs are using this now. So this one study included 20 RCTs. Okay, and they saw that subglottic secretion suction was associated with reduction of VAP, and the grade level was high, the recommended grade level. Okay, it reduced the incidence of early onset VAP, the duration of mechanical ventilation, and time to onset of VAP. Of course, they didn't see any difference in with respect to mortality, ICU length of stay. In conclusion, subglottic suction will decrease the incidence of VAP, and it should be recommended in all settings as per the newer guidelines. So this is a summary of all the important trials and meta-analysis. Many trials actually that will take a whole new class actually if I cover. Important trials are put. So as you can see, the first one, the sedative interruption. Okay, so sedation agents interrupted daily until patients were awake. That decreased the duration of mechanical ventilation and ICU length of stay. So that is why sedation interruption has been included in the VAP bundle. Then you have the semi-recumbent position and the supine position. They saw that the semi-recumbent up to 30 degrees reduced the incidence of VAP. But again, there are a position of the patient. There is not much robust evidence to say that this particular position will reduce the VAP. Okay, studies with high risk of bias is there. Then you have again one more study. They compared lateral prol, semi-recumbent with supine. Again, they saw that semi-recumbent was associated with lowest incidence of VAP. Prone did not reduce VAP. One previously study, they saw that prone, the incidence of VAP was low. Then subglottic suction, RCTs, there was a low incidence of VAP with subglottic suction, but again, not much mortality. It didn't translate into mortality benefit. Then coming to continuous monitoring and maintenance of cuff pressure using a dedicated device. This was not indicated. There was lower incidence of VAP with continuous cuff pressure monitoring. Again, continuous monitoring, more staff is needed, and continuously to monitor can be quite tiresome. So intermittent monitoring itself should be good enough. Continuous monitoring is not recommended as such. Then oral care with chlorhexidine. So lower incidence of lower respiratory tract infection with chlorhexidine was seen only in cardiac patients. In other non-cardiac patients, there was still no difference. But there was a trend towards increased mortality with chlorhexidine in non-cardiac patients. But still, it not much side effects. You can use it. So coming to the take-home message on VAP, I would like to conclude by saying VAP is the most common of the hospital-acquired infection. The incidence ranges from 30 to 40% in the neuro ICU. It prolongs ICU stay, definitely hospital stay, and with it, the healthcare costs go up. You remember there's no gold standard diagnostic test for VAP. So don't forget always to reevaluate all data, that is every 24 to 48 hours after starting antibiotics. And remember, 40 to 50% of patients started on antibiotics will ultimately be not diagnosed with VAP. So you'll be overestimating the incidence of VAP. And simple preventive measures by following the VAP bundle and timely initiation of appropriate antibiotics will lead to better outcomes. Thank you.
Thank you, Saptami ma'am, for that really lucid talk, and you really covered every aspect of VAP. Over to you, Geeta ma'am, if you have some comments and questions.
She's covered almost everything about VAP. See, with respect to the neurocritical care patient, we face more of VAP patients because most of our patients, almost 60 to 80% of our patients are on tube, whether tracheostomy tube or ET tube, and we do elective intubation sometimes. No, either it is no therapeutic use for the intracranial, or because the patient has neuromuscular disorder, so we don't want him to aspirate and then go bad later. One thing I want to highlight is that it is a quality indicator. It's a benchmark for quality indicator in any ICU care. Regarding the usage of antibiotics, I think with the existing antibiogram, each ICU, each hospital has their own antibiogram. Ceftriaxone as the first line treatment, I don't think once you see a patch in the lungs, the ceftriaxone, I don't think anybody will opt for, because already there is an established patch and you have the patient's FiO2 going high and then PO2 coming down, counts are high. So we start with piperacillin tazobactam as the first therapy when there is a documented VAP. Then we move on to carbapenems, depending on the antibiogram only. Regarding the polymyxin B, now that we have a lot of incidents of AKI secondary to cholesterol, we are opting for more of polymyxin B, and we have seen good results.
Yes,
And
yeah.
regarding the duration of antibiotics, as you rightly said, we see very commonly the physicians continuing in non-neuro ICUs at 2 weeks now of antibiotic therapy is very common. But I think
Yes.
it is a very, very bad, practice. We are going towards MDR. We are already pan-resistant patients are there. We are just going for Zavisepta and no very high antibiotics. There's no choice left. I think we need to de-escalate from the day 5 onwards, looking at the trend in the FiO2s, chest X-rays, counts, and PCT should be only taken as a trend to de-escalate, not to diagnose VAP.
Right.
And we here by 7th day we are like we're planning to stop the antibiotics. But anyway, you repeat the cultures, it won't grow anything because already received antibiotics. We go by the clinical criteria. Very rarely we follow till 2 weeks. Very rarely, unless the patient is in septic shock, no, on inotropic support, already is on MODS. So then the antibiotic therapy goes till 2 weeks. Otherwise, 7 days of antibiotic therapy is what's sufficient for a VAP. But having said this, there are sometimes we miss out on VAP, the diagnosis itself, whether VAP or something else. So then we had a patient that we had treated the patient with tigecycline for almost 10 days, and then the PaOTs are not improving, the FiO2 still requiring high. Then we have to think of the other alternative diagnosis like sending viral markers. No, patient came out as what initially was very high con, so it was H1N1 positive. Then very rarely we see all these things, but we do have to rule out. And another thing is having our neuro patients bedridden. DVT is one of the most common problem. So if we don't tackle the DVT, no, with the DVT prophylaxis, that will add on to the pulmonary complication. We'll be treating VAP without, correcting these things. So DVT prophylaxis in preventing VAP, I think, has a big role.
Part of the
So
VAP
these
bundle.
patients, yes, it is a VAP window. And most of all, which I think we all of us agree is the first thing foremost in app bundle is hand hygiene. Hand
Yes.
hygiene, wearing glove. The compliance rate is so down among nursing staff or the doctors that itself is the main culprit for transferring the infection or instilling the infection, and the colonized bacteria can go inside lower down causing pneumonia. So I think she's covered almost everything and all the protocols. I just wanted to ask her one, what is your take on? I think you practice critical care in a general, this one non-neurocritical care, right? So what is
Both,
your
ma'am.
take on? Yeah. What about the early PEG, gastrostomy procedures to? I know it will not reduce the mortality as such, like early tracheostomy, but on a regular basis, we can definitely improve the nutrition, because nutrition is a biggest plays a biggest role in decreasing the VAP and VAP related complications and mortality. Because the nutrition you can very well improve with PEG and colonization of the NG tube, no, that comes down with your PEG, it's a bigger tube, and the residual volume comes down, the gastric residual
Yes, ma'am.
volume. So, what is the take on this one insertion of PEG tubes?
PEG, ma'am, specifically we use for these gastrointestinal CAs. So usually is
Hmm.
recommended wherein you can't use the GI tract for such patients. Usually first NG not working, we go for the FRECA tube for long term. FRECA tube is like that with the inside
Yeah, I know
you
it's
have
a silicone tube.
yeah,
It's a longer tube.
yeah, we use
But
it
the
for a long
problem
time.
is that you will have to, see in the C-arm or the radiologically where
Yeah.
exactly is the tip there. So again, it's a cumbersome thing, and it coming out is a frequent problem because it's a longer tube and it's a very, it's not a sturdy tube, so it keeps coming out. So regarding the PEG insertions, if somebody is requiring the ICU stay, especially in a neuro, if they're requiring neuro care for more than 3 months, if we anticipate let's a
Mm.
large MCA strokes or severe TBI, the GCS less than 7 for a long time, so we insert PEG tube so that the
That,
nutrition is taken care of, so that we can avoid these secondary complications like VAP in these patients.
definitely, yeah. Nutrition. No.
Yeah,
PEG they actually have not used much in neuro patients. For our medical
yeah.
patients, I told you mainly because if gastrointestinal CA is long term requiring nutrition, we have used PEG, but it comes with a cost, a little invasive. Some families won't agree that the risk will be
Yeah,
there. But
it's a
yeah,
quite a bedside procedure, so we keep doing pegs quite often, so that the
okay,
the volume we give and continuous sweets we give rather than the bolus sweets. it's the continuous phase, the volume comes down, the residual volume comes down. So the nutrition is, I don't know, not many RCTs are there, but definitely it plays a big role. Nutrition plays a big role in
Yes,
reducing the.
nutrition play. Yes,
Yeah,
ma'am.
ma'am, I agree. And also in neuro patients, when the gag, cough, and all is affected,
Yes.
and
Yeah.
when the right tube is there, it keeps increasing secretions. And in our
And
ICU,
rice tube
like,
actually blocks the sinuses, and there will be colonization of bacteria. You see a lot of the time sinusitis in these patients. If you do a scopy and see there's a sludge coming out of the sinus ostium, so it's better that you remove the rice tube as early as possible. And of course, if somebody is getting improved in a walkable stage in 2 weeks, no need. Otherwise, it's better that peg is
Pegasus.
inserted. It's a small, semi-invasive procedure. It's a bedside procedure, and it's not very costly also.
Mm.
Yeah.
and what is your take? Sometimes in neuro, there is always a dilemma in diagnosis because neurological illness with fever, with desaturation has very close presentation to VAP. So to have the diagnosis of whether it's really VAP causing that or a wound infection causing that or is it a central fever, that's also some dilemmas we face in the neurocritical care unit. Ma'am, your take
Yeah,
on
Yes.
that?
yeah. Matangi, you go first. I'm sorry, Saptami.
Yes, ma'am. So central fevers can also, yeah, they'll have this tachycardia, tachypnea, but of course the ventilator requirements we'll have to see. It's entirely lung, and we use a lot of lung ultrasound. We use a lot of lung ultrasound day in and day out for all our rounds, or even routine patients, stable patients. We do a routine screening lung ultrasound for all. If that can't pick up X-rays, and of course, still you have an element of doubt. There's nothing wrong and started empirical. Now, we always start out with ceftriaxone. If there's no risk for MDR pathogens, we start with ceftriaxone. And pan cultures, yeah, we'll have to send for such patients. That will be the differentiating because, yeah, they can have high fever spikes. Counts also sometimes can be misleading. So that's how we go about.
Yeah, with our neuro patients, as you rightly said, the PSH is very, we see in at least 130 to 42 patients, and sometimes it goes on till 2 to 3 months after the whether CBI, TBI, or a massive stroke. These patients, we see it in 2 to 3 months' time. So obviously, it is a clinical pattern we see. So it is the chest X-ray findings, and we don't diagnose by PCT, but we send one PCT just to see
Basic.
it if it is not an infective or non-infective origin. And most of these patients, if they settle in with antibiotics, so we don't start off. Otherwise, we start them on Inderol and bromocriptine. That will take care. And
Mhm.
sometimes when that doesn't take care, you will have to give stellate ganglion block, because we have had very bad PSH mimicking like ARDS and this one. Basically, it is the breathing pattern which is abnormal. The
Yes.
PaO2s they maintain. PaO2s
Correct.
they maintain. They need sedation. In fact, in VAP, if you keep sedating the patient, you're going to worsen the case. So
Awesome.
you have to give sedation holiday. So
Yes.
in PSH, if you sedate the patients, you start off this something which decrease the sympathetic drive with either clonidine or bromocriptine. It comes to manageable level. And in fact, you can wean the patients off ventilator if it is PSH, because it is the pattern which is periodic. So whenever
Yes.
the periods are not there, they'll be breathing spontaneously on just CPs. So with very minimal oxygen, unlike in VAP.
Yes.
Yes, that's true. And just one comment from the audience that esophageal sphincter is also affected in long-term Riles tube. So I think,
Yeah.
like ma'am pointed out, PEG maybe future trials will go in favor of PEG as it becomes more accessible. The
Yeah,
technique
in
becomes.
fact, we have collected a few data by doing ultrasound. The gastric volume and the reflex. We want the pH of the oral aspirate. PEG really helps in this aspect of it, because with Riles tube, it's not just a sphincter going bad. We see a lot of erosion to esophageal mucosa, stress ulcers, and they start having hematemesis, hemoglobin down. It's not just the one complication with the long-term NG tube.
And that also can predispose to VAP.
Yes,
NG.
yes. Yeah, because it gets colonizing in the entire NGT, and they can aspirate, because many of the our patients they have pneumocephalus. We can't give head up, so we'll have to make head and flat. So during that, even 2 3 hours is enough for them to just aspirate, micro aspiration. These subglottic ports may be effective, but still there is always a chance of micro aspiration in these patients.
Microaspirations
So
can.
anything which prevents colonization of the bacteria in the upper airway. Sometimes you see we very bad practice of keeping the nasopharyngeal airway or oropharyngeal airway for long term, even in tracheostomized patients. So that itself is a the source for colonization. So, as much as possible, minimize the instrumentation in the nasal cavity and the oral cavity. The early tracheostomy is what we believe in, probably within less than 7 days or less than 4 days. Sometimes when we know that GC is not going to improve.
Thank you, ma'am. Thank you so much. And it was a lovely discussion. It was wonderful having Sapthami and
Thank you.
Geetha, ma'am. And hope to meet you in many more forums. On behalf of NCSI, I take this opportunity to thank both of you for this wonderful session. Thank you very much.
Thank
Thank
you.
you, ma'am.
Thank you for giving me the opportunity to talk. Thank you, ma'am.
Yes.
Thank you.